I'm Julie Ross.
And I'm Elizabeth Cohen.
And this is the Parenting Horizons podcast.
Julie Ross is a parent educator and counselor with over 30 years of experience in private practice.
Elizabeth is a clinical psychologist with over 20 years of experience in private practice.
Perhaps most importantly, we're parents just like you.
Through conversations covering a wide range of different parenting topics, challenges, and roadblocks, we hope to give you some practical tools that might just help make parenting a little bit easier.
Nobody's perfect, and parenting is challenging, to say the least. But with a few skills under our belts, we might just be able to be good enough parents and enjoy the journey and our children a little bit more in the process.
Hello and welcome back to the Parenting Horizons podcast. I'm Julie Ross, and I am here again with my co-host, Elizabeth Cohen. And we have a guest today. I'm very excited about that. And I'm going to let Elizabeth start.
Thanks so much, Julie. I also love being with you here on the podcast. It's such a gift, and I'm really excited to introduce and welcome our guest today, who is very wise, and I know everyone's going to learn so much from her. So I'm so happy to introduce Dr. Joanna Robin, and I'm hoping, Dr. Robin, that you can tell us a little bit about your background before we dive in deep. So can you tell us a little bit about where you work, what you do, and we'd love to hear it.
Great. Well, thank you so much for having me. It's a pleasure to be here. I'm excited to talk to you. So I'm the director of Westchester Anxiety Treatment. It's a group private practice in Westchester, New York. And my area of expertise is in the treatment of anxiety and related disorders, particularly OCD. So I'm very passionate about providing cognitive behavioral therapy, children, adolescents, adults, throughout the lifespan, anything related to anxiety and related problems. My background is in clinical research trials and writing articles about parenting and emotion regulation and anxiety. And I'm also a co-author of the OCD Workbook for kids as well. So it's an honor to be here and to talk to you today.
Thanks so much. Yeah. And I was just letting Joanna know earlier that I had recommended your book to a client of mine who's working on it with her daughter, and it's helping her so much. So it's really, we'll talk a little bit more about the book, but it's really so accessible for people. And I think someone who, like you, who has so much experience in research trials, in the science of CBT, really did a beautiful job bringing it to lay people who can also work on it just at home. Yeah, it's a great book. It's such a great translation of the theory. So that's actually a great place to start about lay people. So I feel like OCD gets in popular culture, the idea of, oh, you like to wash your hands a lot, or you like to order your clothes. And sometimes people will just say like, oh, I'm so OCD, as if it's some sort of adjective. And so I just thought we could start by you maybe just sharing a little bit about kind of what some of the misconceptions are about OCD and what it really is. That would be really helpful.
Yes, I think that's such a great point that I talk a lot about with my clients that I work with, especially the teenagers, because when you have OCD, it's painful, it's difficult. And when people kind of just say, oh, I'm so OCD, I need to, color code my study materials, or I'm so OCD, I need to kind of have my, clothing like folded in a certain way. And that's very productive. Maybe when you color code your binders for each subject, or you kind of, color code your closet so you can find that red shirt you want or that blue pants that you wanted. So that's very productive way of working. And OCD is the opposite. OCD is unproductive. It's wasting your time. So I think it can be painful when people with OCD hear people just throwing that around. Oh, I'm so OCD. And because that's not their experience. Their experience is a painful experience where they're very unproductive and wasting their time, but they feel they have no other choice. Very common misconception. And I think that's important to talk about. I actually talked to a friend who said, I was told her I was coming to speak about OCD. And she said, oh, people at work say, oh, this art project I was trying to teach these kids and I wanted to do it a certain way. I had a vision for it. And they said, oh, that's her OCD. And I said, well, I'm going to bring that example up because you don't have OCD. And she's, I don't. And I said, no. So, yes, I think it's very common. It's a really
Yeah.
good question.
Yeah, like somehow it's become like you're so particular. It
Mhm.
reminds me of like when you're interviewing and they tell you, like, when someone asks you what your weakness is, it's to say that you're so organized. It's like
Yes.
and I think you're bringing up such a good point, which is that actually in the diagnostic statistical manual that we use to diagnose OCD, part of the criteria is that it takes up a certain amount of time where it becomes interfering and distressing. So that's actually a really important piece. And I think that as someone who has OCD, I think it would be so minimizing if people were just kind of throwing it around in that way. It's a whole other
Right.
topic that we should probably talk about, but just about how while social media has been so helpful for getting information and advocacy out about mental health, it also kind of waters it down. So I think that's also probably where it comes from, right, Joanna?
Correct. Absolutely. I think a lot of people just throw the term around, but understandably, they don't know what it is. That's okay. And it's hard. I think that's, that's why we're here, right? To help, let people know what it is and what it isn't, right? But I think that is
Yeah.
a big factor in social media for sure.
Yeah. I'm wondering actually if you could talk a little bit before we talk about CBT for OCD, just about the different types of OCD. So, kind of obsession only OCD and more compulsion OCD, or the combo.
Mhm.
Would you be able to talk about that a little? Because I think that's something our listeners might not necessarily know the distinction.
Yeah,
Right.
I think that's a great question. So, I mean, OCD involves, I'll just say in general, there's intrusive images, thoughts, sensations that occur that are distressing and unwanted. And then the person does something, which we would call a compulsion, to get rid of that feeling, that sensation, that thought. That image potentially because it's so upsetting for them. So they engage in a compulsion or ritual or what we call like a rule to get rid of that feeling. And so that is the kind of the gist of OCD. It involves those two parts, the obsession and the compulsion. And it always involves those two parts, which is really interesting. And a lot of times people will, come to me, or maybe they've done their own research and they'll say to me, oh, I'm a pure OCD. And, it's interesting. I think that's what you're kind of talking about, which kind of shows up. And actually, there's no such thing as a pure O, and then what happens is that people are engaging in mental rituals. So they believe that it's just
Oh,
obsessions that are occurring. And actually, they are engaging in mental rituals. They may not be aware of it to get rid of that obsessional or intrusive thought. So it actually
Oh.
doesn't exist, but a lot of people think it does. Again, social media or someone told them about it
mhm.
or things like that. Very common, but it's a very common misperception. But with OCD, it always involves that compulsion piece. It just might present in different ways.
Wow, that's so interesting. And I think also with kids, that would be so hard because you don't know they're necessarily having it because it's internal. Can you give an example of a kid that you worked with who had that and one of their mental compulsions? If you
Sure, absolutely. Yeah, there's so many. I guess I'll give one where I'll give some like kind of simple ones and I'll give some more complex ones, right? So intrusive, maybe a child is having some intrusive thoughts where they keep having images of something upsetting. So I worked with one child who had this upsetting, intrusive image of a dinosaur from Jurassic Park from the ride kept coming into her head. And then she had to say some things in her head over and over to push down the image and to get it away. And she had to kind of say these certain
Mm.
sentences over and over in order to get rid of it. So that's kind of like more obvious, kind of simple one where it's like, oh yeah, that's like it's very clear you're engaging in this mental ritual that you're doing to get rid of this upsetting image in this way. Maybe a more complex one I see more in teenagers and adults might be in the format of fast forwarding. So they maybe got an intrusive thought like, oh, what if this relationship with this boy that I like doesn't go well? Like, what if he, what if like the conversation doesn't go well, and what if he doesn't like me, or what if I break up with him, what if I hurt him, because a lot of times people with OCD are really worried about hurting other people. So what if I hurt him, and he's mad at me, and then everyone's judging me for being a person who just leads someone on. So that next thing, that those are intrusive thoughts, and you might think, well, those just sound like worries, right? Like a lot of teenagers might have that worry. But then the next step, what that teenager might engage in, is a compulsion where she fast forward and imagines every single conversation for hours, and different ways it could go, and different things people will
Wow.
say. And then I had one patient who did all of this for like at least 2 to 3 hours. She called it worry, but it was actually a compulsion. And she finally, in the
Wow.
end, said, well, if this is going to happen, I'm just not going to date this guy. So it led
Mm.
to, unfortunately, avoidance. It led to a lot of interference, a lot of time. Teenagers don't have time to be engaging in compulsions like that, right? So that's really
Yeah.
upsetting. So that it can be very something simple, or it can be something very
Uh-huh.
complex and very confusing, because this teenager in particular didn't really know that that was a compulsion until we started talking about it. And I didn't know it. So
Mm.
I started really asking some questions. And I think that's where it's confusing for parents too. Like, not, my kid's a worrier, but they may not be. They may be engaging in some of these compulsions.
Yeah. Such a good
Wow.
point. Such a smart point. And I think what parents see, that I see in my practice, I just had a client the one who's reading your book, where the kids come to them like for reassurance. That's what we would call it. But they think their kids are just worrying. And I actually had to say to my client, like she said something like, oh, well, she just loves to talk to me and we have these close conversations and we're really connected. And I said, I'm sure you are that. I just want to say that those conversations are not connected. Those are reassurance. Those are compulsive conversations. I think it's really hard for parents to disentangle that, as you so honestly and humbly said. Like, it was hard for you to
Yeah.
figure out. And I think that's hard for parents.
I think that's a great point. I think that's one of the hardest things. If someone asks me what's the hardest thing of being a parent with a child with OCD, is seeing your child in such distress, and needing that
Mm.
reassurance. And as a parent, we're sort of like innately and sort of trained to like provide that comfort, provide that reassurance. And I have to say to parents, actually, the way to show love and the way to show warmth is to not provide that reassurance, because then you are engaging in that compulsion with that child. Sometimes we call it one and done, right? You can say, okay,
Mm.
are the doors locked? Sure, you lock the doors, but we're only going to let that question be once, and we're only going to, as a parent, we're only going to answer it once. So we might just say, yes, the doors are locked, but that child with OCD is going to, it's the doubting disease. So they're going to ask again, because even though they know maybe down in the deep bottom of their heart that that door is locked, they trust their parents, OCD tells them not to trust their parents, and just to ask one more time or even two more times. And as a parent, we have to sit with our child's distress in that moment and not
Mm.
provide that reassurance. And that sometimes just feels so counterintuitive to being a parent. But that is the thing we have to do. And I think also part of that is believing in our child that they can handle that distress, because sometimes we don't think they can. We don't know they have the skills, and that is what makes it difficult.
I have a quick question about that. I agree with you 100%. We've talked about this on the podcast before about parents' unwillingness to sit with their child's distress because it causes them distress and they want to get out of the distress. And so I'm a big advocate of being okay with if your child is distressed. If there's a lion about to eat your child, that's a whole different story, right?
Right.
But for normal life, we don't need to worry about that. So my question is, when a parent sits with their child's distress, what should the parent do to replace their old behaviors, which is to continue to reassure, or possibly just cut their child off and said, I've had enough of this. What can the parent do when they're sitting with their child in that distress?
That's a great question. And what we try to do is have parents do something called a supportive statement, and which involves validation and belief in their ability. So it always has two parts. And that first part is that validation part. Like, I know OCD is really messing with you today, and I know you're strong enough to fight it. Right. So, or I know OCD wants
Mm-hmm.
you to ask one more time if I put poison in your lunch today. And I know that you can handle this feeling. Right. So we're just believing in their ability. And that helps us because it gives us something to say, which I think is really important because we're like, it's hard to say nothing, right? We either want to like, stop it
Yeah.
or reassure. We want, like
Yeah.
you said, so true what we want to do. And this gives us something else to say as a parent. And it really just shows our belief in them too. And I think that's so important. And it helps us then believe in them when we say it.
Sure. I have another question, which is, what if it hasn't been identified as OCD?
Mhm.
So can a parent say, I hear that you're worried about that, as opposed to, I hear that your OCD is really messing with you today?
Oh, yeah, I love that. And I think once a child is in treatment and they know they have OCD, and we've maybe come up with
Sure.
a fun name for it, and maybe we don't even call it OCD, maybe it's, some other cute name or something silly. We try to make it something silly because we want it to be less threatening. But yes, it can be any form of anxiety. Like, I know you're feeling really nervous about us, leaving you with a babysitter, or I know you're feeling really nervous about sleeping on your own tonight, and I believe in you. Right? So we can always do those
Great.
supportive statements for sure. That's a great question.
One of the things that I always find so helpful about your book and the way you treat OCD is actually what Julie just brought up about the naming the OCD. And my understanding, and tell me if this is right, Joanna, is that because OCD can feel like it's us, like I am the thought essentially, like that separating it out helps. So can you explain a little bit about why naming it would be helpful for parents if they decide to do that or in your treatment?
Yeah, I think it's such a great technique. And name anybody. I think worry in general could be named. I think OCD should definitely be named because I think children feel so fused with it, or parents feel like, why do you need to ask? I've just reassured you 15 times. Like, why are you keep asking me the same question? Or why do you just like keep washing your hands over and over again? Or think you need to go to the bathroom? You've peed 4 times. Like, you don't have to go anymore. Like there's no pee left. Like, they're really trying
Mhm.
to use logic. And I think when you name it as something other than the child, it helps the battle stops. And really it becomes,
Mm.
we want to think about it as a parent and child as a team together. So when you're part of that team and naming it as something else, it brings the child and parent closer, and they're on a team together,
Yes.
and that the OCD is on its own team, and we're not friends with that OCD, and we're going to try to beat that OCD. And sometimes we're not going to win,
Mm,
and we're not going to be so mad at ourselves when we don't win, because we're in it
mm,
together. We're here to try our best. But we know sometimes that OCD is going to win. So it really kind of helps with that teamwork approach. It helps make it not feel like they're doing something wrong that they can't control. It really is a form of empowerment. I think the main thing about it is just to make sure it's not a scary name, and
mhm.
make sure it's like a silly name, because we don't want people to feel intimidated by their OCD. We want them to feel empowered by it.
Yeah.
Right.
I think it's such a great intervention too, because my experience working with people with OCD is that they say, I know this isn't logical.
Mm-hmm.
So they already
Mhm.
are there. You don't have to convince them that it's outside of them. Like they know it's not really their empowered self, if you want to call it. And so I love that idea of also being able to have the parents work together on it, because it can create so much frustration. So that's such a gift. Um, so can you talk a little bit about kind of the standard treatment for OCD, CBT, with what you use for that if
Sure.
someone was to come into your office, and also what parents can also do in the same way. But
Yeah. So, well, the gold standard is something called exposure and response prevention, kind of known as EXRP. And basically, that is what it sounds like, and it's basically where you are exposed to your fears, and you are not allowed to engage into your compulsions. The gold standard involves, the first part involves psychoeducation. So really educating both parents and children about what is OCD, what's not, kind of like what we're doing already a little bit today, how to talk about OCD, and really understanding what OCD is telling you, and what the child is afraid of happening if they don't engage in these rituals. So that's a really important thing, because a lot of times I'll ask parents, well, what do you think your child's afraid of happening if they don't do the ritual? And that's just not a question parents ask. It's not, like, I don't know. They just do this thing. I actually haven't asked them why they keep doing it, or I haven't maybe asked it in a way that, like, the answer has come out. So it's really understanding what their feared consequence is going to be, so that we can design the treatment intervention really to be effective. So I can give kind of like a classic example, right, of that. Might be a child who has to, at night, they have to say, good night, I love you, a certain amount of times, maybe in a certain order, in a certain way. And then the parent has to say it back to them the exact same way. And if it doesn't, they don't feel like it was just right enough, they might need to ask the parent to do it over again. And that's a very classic example of the parent engaging in the ritual with their child. The exposure might be, so that the fear might be that if the child doesn't say it, something bad will happen to their parents, and they might die and not know that they love them, or something, bad during the night will happen, and this saves and protects their parents. And maybe they know, that's not so logical, right? As we were talking about before, but they're not 100% convinced, and it's not really worth not doing it. Their parents' lives are too important. So they really are willing to engage in these rituals, and the parents also engaging with them. So what we would do is kind of, again, do that psychoeducation, explain the rules, we're not going to do a lot of logic, because we're not going to ever convince someone 100% with OCD that this is silly. But we're going to have a willingness for them to maybe try something different, to maybe embrace the doubt, like a possibility that maybe you're not keeping your parents so safe, or other kids aren't doing this. We might kind of involve a little bit of that, but really we're going to talk about being brave and empowering them to change the ritual up a little bit. So the exposure might be to not say it exactly the same. Say goodnight, but not say it 3 times. Maybe it's 2 times. And that might be so we're kind of, we're not engaging in that compulsion in that way. And over time, the child learns that actually, oh, I didn't engage in that compulsion and nothing bad happened. And over again, they continue to do it at higher levels until the OCD is, reduced.
Okay. I have a quick
Mhm.
question. What if you can fast forward in time, and let's talk about a segment of the population that I think has been radically affected by COVID, and it's kind of the late adolescent period of time,
Mhm.
right? And what would you say to parents of a late adolescent slash young adult who most assuredly has high anxiety, oh, absolutely, almost positively OCD, but and the parents understand that this is going on, but the young adult is very much in denial about it. It's not a psychological issue, it's a physical issue,
Mhm.
right? What could you, I don't know, I mean, that may be just way beyond the reach of the podcast, but I just wonder if there's something that parents can say to you know, their 21 to 25-year-old, because they're no longer of the age where they can just drag them into a therapist's office.
Yeah, that's a great point, right? That's the tricky part when you see your child struggling, no matter what age, right? They could be in their 20s and late teens, and we really cannot drag them in. And I think that
Yeah.
is so hard. Again, talking about parents seeing their kid in distress and wanting to help, and here in a great way, wanting to get them maybe therapy. So I think what we typically would talk about is talking about the how this is interfering with this person's life. I think I might go there and say, and talk about like, wow, there's so much time you need to spend in the bathroom before you're able to leave for work or be able to leave for class. That's taking you 2 hours at night to do your nighttime routine. Or you need me to come in and turn the faucet off 3 times for you, and I have to be part of it. This seems like it's getting in the way. So I try to like talk a little bit about the interference level that it's causing in those ways. To see and talk about maybe the cost of the compulsions, like
Mm-hmm.
there's a cost here to
Mm-hmm.
this. Yes, you're getting it all done, but you're not getting any sleep, or you're getting all, but you're not going out
Yeah.
and having a social life. So really trying to talk about it from a cost perspective. The other thing I would
I like that.
say is like what's big now, is really working with parents on reducing their level of accommodation. So parents might be, as I mentioned, that example where the parent might be coming in to turn off the faucet for their 21-year-old, because if the 21-year-old did it, it would take about 30 minutes because they'd have to do it over and over again. This parent can just do it once.
Mm-hmm.
The 21-year-old doesn't have to see, but they're engaging in their OCD. So
Right.
then we talk to parents, how can you gently, in a loving way, slowly reduce your accommodation because you care and love your child so much?
Right. I like that.
Yeah. It makes me think about the stages of change, like where people are willingness to change with any sort of um, difficulty that they're experiencing, whether it might be substance use or I mean, it's a compulsion, right? It's the same
Right.
idea of a compulsive behavior that you think is going to make you feel a certain way. And it's really hard. It's so hard to see your kid struggling in this way, and not be able to do much. And so what came to me when you were asking that, Julie, was also like curiosity. I think with OCD, it's really easy to be like, this is ridiculous. This makes no sense. And as Joanna said, like come at it with logic, as opposed to, and I really appreciate your point, Joanna, about like, what's the curiosity of, oh, what did you think was going to happen? Or why are you doing this? Or how does it feel when you do this compulsion? Is there a part of you, trying to separate it out? Is there a part of you that's really bummed that you're always late to things, but also really glad you have something to hold on to? And I have a client now who can say like, I know it's OCD and like there goes my OCD and I'm doing it, but this is a time where I just broke up with someone, and so I'm not able to really face my compulsions, like to be able to kind of have a dialogue with it, instead of coming down kind of harsh on how it makes no sense.
I really love that. I love the way
Mm-hmm.
you're talking about that, those two parts of oneself, and really validating that side of that doesn't want to change, and scared to change. Right. Yeah. So I love the way you're talking about that. And I think I love to talk about it as like not all or nothing, right? So like you said with
Mm-hmm.
your client who just didn't have the emotional capacity to not engage in her compulsions because some life event occurred. And I'll say, okay, I get that. That makes sense. So what are we going to do to do something a little bit differently now? Yeah, you gave in, OCD won that battle, but what's another one you're willing to kind of push forward? So it's all is not lost for the whole week potentially, or the month, like that there's like
Right.
different ways we can sort of get back in there. So I'm always trying to encourage that not that all or nothing thinking.
Can you talk a little bit about your book, and because tell me how parents can use that book and kind of what ages maybe it's aimed at?
Sure.
I mean, not the age of the parents, I think that would be really helpful for our listeners to hear.
Absolutely. So it was written as a self-help book for kids ages 6 to 12. And it is really to be used with a parent. It doesn't have to be, but a parent can guide the child with it, or the child can do it alone if they're older, but it would be hard for a 6-year-old to use it alone. And there's lots of activities in it. And again, we try to make CBT fun, and exposure and response prevention as fun as possible, even though it has been called by the New York Times the cruelest cure. So we try to make it as fun as we can,
Wow.
given that's it's known to be. So, but we try to make it interesting, and again, maybe drawing out your OCD is one activity that we might do. We try to make different
Love it.
analogies. We give examples of other kids' OCD, and so the kids don't feel so alone. I mean, kids really, especially younger kids, no one's talking about OCD when they're little. Maybe they are when they're teenagers, they're bringing it up, but when they're little, they're not
Right.
talking about it. Elementary school years, and they feel so alone. They feel sometimes so ashamed of these symptoms, and to know that they are not alone, and that we give a lot of psychoeducation about that piece of it, to feel like that their other kids are going through this too, and especially when they see an example in the book of a kid who's kind of similar to them, and they're like shocked about that, and they feel so validated that they're not the only one. Because a lot of times, when kids come to our office, especially, they are like, you've never heard this one before. This is so weird. This is so embarrassing. I have these type of images or thoughts, or there can be really embarrassing ones, like, I'm afraid I might have sex with my mom, or, I am having intrusive images, that maybe I might hurt someone, and I don't want to hurt someone. So these can be shameful and embarrassing. So we really try to, in the book, to try to make kids feel validated, in that way. And then we also giving ideas and examples so that they can do exposures with either parents or on their own to practice facing their fears in these ways.
Is there an age at which OCD is more likely to surface
Yeah,
in a
it
child?
can. I mean, it's, the average, I guess, is like a childhood, late childhood, potentially, it can any age. I see it even in ages like 3 or 4. Right. So I treat it all throughout the
Mm,
lifespan, where parents will say to me, they had to get their legs to the pants of their pajamas on in a certain order as like a 3 or 4 year
mm,
old. They saw earlier signs like starting. Sometimes sensory symptoms can come up, and be related to
mm,
OCD. So the socks needing to be a certain tightness or a certain feeling, or the sneakers not feeling right, or the pants not feeling right, or some of the tag situation, where people might think it's like an OT issue. Sometimes it actually is an OCD issue. So for young kids, sometimes they don't have a feared consequence, like a thought that might be coming up. They might have something called just a not right feeling that just doesn't feel right, and they
mm,
need to make it right. So we'll see
mhm.
that a lot of times in younger kids, versus, I'm afraid if I don't do this, something bad will happen to me or to my family, or, I will, be contaminated by something. They don't typically have those type of thoughts until maybe more childhood, teenage years.
I'm glad you're bringing that up, because I think it's really important for our listeners to just kind of keep their eyes out, not in a pathologizing way. I'm
Right.
curious if you agree with this, Joanna and Julie, that if you're noticing any sort of rigidity around something, to kind of play around with it and say, oh, today, let's put your pants on backwards, and kind of notice what the response is, because that can really give you some information. And this is for kids who don't have OCD. Even just the ability to be
Right.
flexible and to be able to try new things I think is an important skill that, as parents, that I think it's good to instill. Do you agree,
I
Joanna and
love
Julie?
that. Yes, absolutely. And being flexible. And I think a lot of times as parents, we're told, provide structure, provide routine, make the nighttime
Mhm.
ritual always the same, right? Have a bedtime routine. And as parents, we can get overwhelmed by like what we have to do. And so we think we have to keep that system. but actually we want to raise, I think, flexible kids. We want to raise kids who can go with the
Yes.
flow, I like to say, right? And so we want to be able to change things up a little bit and say, it's backwards day, right? Or it's opposite day, or it's
Yeah.
wacky Wednesday, and we're going to just do something a little bit differently. So I love that idea.
I
Yeah.
love that idea too.
Good. You do. Okay, good. Yeah. And I just wanted to also say, to go circling back to your book, one of the things that I find in that parenting workbook, essentially for parents and kids to work on, is you cover so many possibilities. I think it's one of the things that I imagine was hard about the book is there's so many ways, if you, as you've shared, that it can come out, and you cover so many, and it's such a flexible book. I mean, it's funny, right? For OCD, it's a very unrigid book, an unrigid workbook that you can use this worksheet, you can draw, you can paint, you can sing. Like there's all these ways of engaging with it. It brings so much creativity. So I just wanted to make sure to add that to what you were saying about your workbook.
Thank you.
Another question I would have is, can we differentiate between something that may just be a phase for a kid versus, oh, there's kind of a diagnosis needed here? So I remember when my daughter was 7 years old, which is an age at which they can be very Eeyore like, for lack of a better word. I remember when she became incredibly afraid of poisonous mushrooms. Now I live in Midtown Manhattan. How many poisonous mushrooms do you think are on the street? Right? But she became incredibly afraid of poisonous mushrooms. What if, all of those intrusive thoughts that you're talking about? What if? What if somebody went to the park and they accidentally stepped on a poisonous mushroom, and then they came over to visit us, and then the poisonous mushroom dust from their shoe got on the floor of our apartment, and I touched it, and then I ingested it, and then I died, right? So, I mean, listen, if I had a thought in my head about it, I probably would have taken her in to see somebody. But I really didn't support the thinking. I kind of said, you're fine, and that's not going to happen to you, and you can handle everything. And it passed. It was most definitely a phase, unless maybe you're going to tell me, no, actually it was OCD, but it was a short-lived OCD. I mean, how do parents differentiate?
Yeah.
Because my daughter is a very high functioning therapist now. So
Yeah. No, I think it can present in so many different ways like that. And it's interesting that you brought up that example, because I also treated a 7-year-old with that exact same intrusive thought. And
really,
yes. And so when you said, I said, oh, well, I know this one very well. And that's why it's very validating when I say to kids, oh, I've seen that one. Yeah. So I have seen that one. And the exposure was, his mom brought in mushrooms, and we had a catch in my office with mushrooms
oh,
falling all over my office. I had a lot to clean up that day. So yes, your daughter is not alone in that. But yes, I think, right. And then going back to what Elizabeth was saying about not pathologizing, right? Not everything is,
mm,
I call it, some things could be OCD-ish, not OCD
got it.
necessarily. And a lot of times when
Right.
parents are bringing their kids in for treatment for OCD, where it really is OCD, they'll say to me, I had this phase where I couldn't step on the cracks in the sidewalk, or I had to walk in certain patterns, or I had to tap things a certain way. But then I stopped doing it. I realized I didn't need to do it anymore. So yes, I think
Mm,
there are definitely phases of where people go through that. And it is not OCD, and maybe it's a little OC-ish, but you were able to kind of say, reassure her. It sounds to me like a one and done, and that worked. Right. So
right.
that helped her. And so with kids, they don't know these answers. They don't know how things get tracked into apartments and mushrooms and things so we do
Hmm.
need to give them education about how the world
Hmm.
works in this way versus adults, where they would know the answer, and it would be probably more pathological in that way. So we do need to give that education to
Yeah.
kids.
Mm.
And definitely can be a phase. I always say, when parents
Hmm.
ask me, well, how long is treatment going to be? And I say, treated OCD in 1 to 2 sessions, and I've treated in many years. So I think it really is a range. And maybe that child who I did 1 or 2 sessions, all they needed was a little psychoeducation about OCD
Right.
or about, intrusive thoughts and compulsions. And they're like, oh, that's all there is? Okay. And gone. So it
Mm-hmm.
doesn't necessarily, it's really about the level of duration. How long is it lasting? We think about it, we were talking about before, like, is it lasting over an hour or more a day? Is sometimes our general, like, how long is it getting, how many hours a day are you thinking about it? Is it interfering? How much distress is it actually causing? So are you avoiding situations because of, your OCD? So we want to look at all those factors before we call it real OCD and in that way.
Yeah, and I think you're pointing out something that's really important for anyone who's listening, who's wondering if their kid might be showing some symptoms of OCD, which is if you decide to meet with a practitioner, to have someone who does a really thorough history. Because Julie, I think it would be different if your daughter had the mushroom thing. You told her no mushrooms, but then she had the cactus thing, and then she had the elevator thing, and then right, so
Right.
it's like we want to look at the kid over, right, Joanna, like over time, because I think a lot of times when you said that, what your client said, like, oh, and then I got over that, but then sometimes people I've worked with are like, and then it became this, so it doesn't have to be the same
Right.
compulsion. It's like, is that how their mind manages uncertainty, essentially? Would you say that's right,
Really great
Joanna?
Oh,
point.
yeah, that's a great point. I'm thinking about an adult I worked with, and when she was about 12 or 13, her fear was that her intrusive thought was that she somehow got pregnant. And that she
Oh.
was contaminated by sperm, and somehow was but that, when she wasn't treated for it, it went away. And then when she was in her 20s, she developed a new form of OCD. So she had that history
Mm.
of it. So it was maybe a phase for her, but it did come back. And that's not the case for everybody. It doesn't, for some people, it doesn't come back
Right.
ever.
Exactly. So, Joanna, something that has been coming up in my practice, where I've seen OCD being questioned, and um, parents' concerns and noticing, is with PANDAS or PANS. And I'm wondering if you can explain to our listeners a little bit about what that is and its connection to OCD, and what might be best and what they might be seeing.
Yeah, sure. There are situations where children have strep, the strep infection in their body. And as a result, they develop OCD symptoms. They can also develop other types of symptoms along with that. Sometimes there's a lot of dysregulation, behavioral issues, sometimes enuresis, which is having accidents, separation anxiety, tics. So it can come out in different ways, but it is related to having some form of strep infection in your body. And usually it is a very sudden onset. So you have like a typically developing kid with, maybe some typical minor worries, fears, nothing really big. And literally overnight, what parents will talk about is having a child who's engaging in multiple compulsions, or
Mm.
engaging, and sometimes there's tics as well. And they are more dysregulated, difficulty sleeping sometimes. So I will definitely see that in my practice. I get calls about that. I think now pediatricians, in the past, I would say 5 to 10 years, are more aware of that this is a real thing. I would say about 10 years ago, they're like, that's not even a thing. That's not real. And I would say, well, I think you need a new pediatrician, because it is real. It really does happen.
Hmm. Hmm.
And I usually, ask, the first thing I ask is to have people have a blood test, because that's really, the best way forward. And then potentially they might see a PANDAS expert, who can help them more on the medical side, to help them potentially with medical interventions such as antibiotics. As a cognitive behavioral therapist, though, I can be very helpful. They can get help for the medical side of things, but also CBT is also a noted intervention to help kids who have a PANDAS diagnosis as well.
Great, thank you. And I just want for our
Yeah.
listeners to say the term PANDAS refers to pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. It's a mouthful, but it's essentially
Yeah.
exactly what Joanna said, those symptoms coming out after neuropsychiatric symptoms coming after strep infection. Thanks.
That was awesome. Yeah,
Mhm.
I appreciate that clarification and that information for our listeners.
And then I remember when it first started coming out that pediatricians, as you said, and even some psychiatrists would think, well, because it's quick onset, must be just physical, don't need treatment. And it's so important to have treatment and for the family. I mean, just to think about when a quick onset of a psychiatric condition must do to the family and and the kid and the shame. And so I really want to encourage people that are now specialists in PANDAS really to not minimize it or think it's just a medical condition. It's really, it needs a holistic approach.
Absolutely. Absolutely. And right. And it is it's so dramatic for parents and so scary for them where you truly have a
Yeah,
different child overnight. Yeah. It's can be
yeah,
very overwhelming.
Yeah.
yeah.
So, what's something that you would tell a family who, because one of the things that I wanted to just bring up in the time we have left is the likelihood, just the genetic load, essentially, like how
Mm.
high OCD runs in families
Yes.
and how hard it is. I guess I just want to name how hard it is if you're a parent who has OCD to guide your kids in the exposures and to really get the help. So can you talk a little bit about that? Do you see that in your practice and how do you move through that?
Yes, I do. And I think it can be very complicated. I see a lot of parental guilt, right? That they've passed this down. I see that as they
Mm.
feel so guilty that their child has a form of OCD, or especially when it's the exact form of their own. It typically isn't. It usually it takes some other type of form, I would say, in my just clinical experience, but just feeling so guilty that they passed this down. And they'll say, but I had a totally different childhood than my kids. How did this happen? And I feel so bad. And we'll say, okay, it's genetics. It's no one's fault. We really want to take out the fault, blaming in any way. And that I say, well, the good news is you understand what your child is going through, and you can validate them and know how hard it is. But sometimes it's really hard when it is a similar type of compulsion that they're engaging in, especially, cleanliness type of ones, or I'll see that more with like, I talk a lot about bathroom behavior. I'm sorry, wiping after toileting. Like that sometimes will maybe the child didn't even know that their dad had that same behavior, but spending hours in the bathroom. And that's really hard where a parent sees, that their child is now engaging in the same type of behaviors that happens. But I think, again, we try to say, like, we're all a team, we're all working on our own OCD, and try to be a coping model, we call it, and saying, like, I'm not perfect, sometimes I mess up, sometimes my OCD wins, but I'm doing my best, and I'm, going to work hard to try to fight my OCD. But it is
Mm.
a little bit tricky for parents who are struggling on it as well.
Yeah, and
Mhm.
it feels kind of like a meta comment, but I think also because one of the symptoms of OCD can be the guilt and the shame and the control that I can also, right, that they're also, it can become an OCD compulsion that they created this in their kid,
Yes, yes.
right? Or like an intrusive thought, kind of like this was my fault. And then that can become a rumination.
Yes, absolutely. I think, right. I mean, definitely could, 100% could. I think they, are really trying not to engage in compulsions in front of their child. I think that,
Mhm.
and the shame and the secrecy is really tough. And maybe when they're little, they can get away with it, or, like, we just take our, shoes off and we just wash the bottom of them. And, this is just something we do. And then as they get older and they see that they're not able to kind of maybe sit on their own bed, or they need to wash more in the shower, and they've taken it up a notch. I think that's where the guilt kind of comes in, like where they didn't realize
Yeah.
Right.
this was going to happen.
Yeah, of course. Of course.
And I just want to say that I think that guilt is not a helpful thing.
Mm-hmm.
When we for lack of a better word, indulge in guilt and ruminate about the guilt, it's not helpful. It's not going to further our children's mental health in a positive way. And I know it's really hard to let go of guilt because, there is a function for that emotion. Good guilt, what I would call good guilt, is something that is our moral compass. We were driven by that. But bad guilt, which is blaming ourselves for things that we have no control over, is it's not going to ultimately be helpful for our kids. And I think if parents find themselves feeling overly guilty, that might be an opportunity for them to go get some help around that feeling, because it's just going to hold everybody back.
Yeah, such a good point, Julie. And I think also to say that I when you were talking, I was thinking that guilt is a connection blocker because you become
Yes.
so focused on yourself, you can't connect to the kid. And when a
Yep.
kid is in distress, and Joanna's described so beautifully how it's a treatment that they work together, that your guilt is just pulling you away from the kid, not bringing
Yeah.
you closer.
Precisely.
Yeah, I love that
Precisely.
distinction, right? The good guilt and that bad guilt. That really
Right.
it's a useful emotion, but if we do something with it, right, and not
Yeah.
let it block us.
Exactly.
Exactly.
So,
Exactly.
so Joanna, is there anything that we haven't asked you about OCD that is a burning desire that you have to share with us?
I can't think of anything else that is trying to come out. No.
If you had to leave our listeners, Joanna, with one or two, you know, salient points, what you consider kind of to be the most important, what would those be? I know it's hard to sum up, and we've covered a lot of ground, and it's been amazing. I just wonder if you would be able to share one or two things.
Yeah, I think a theme that I think about, I talked about a lot already, but is empowerment, and this idea that we're stronger than we think, our children are stronger than we think too.
I
And I
love that.
think that, it goes back to what you were saying too, Julie, about, just your parental distress and seeing when they see their children in distress. I just think kids can handle their distress if we give them a chance, and that
Yeah,
will help them feel stronger, help them feel braver. So I would leave parents off with thinking about that, is just really doing it in a systematic, slow, loving way. Because I
hmm,
think helping your children be brave and helping them face their fears is a loving thing to do. And I think parents sometimes think of it as potentially mean or cruel, and I think we have to kind of shift
right.
that, that it is not cruel to not give that reassurance again, or to not wash that water bottle because it might have touched the bug spray that was next to it. It is not a cruel thing to do. It's a loving, kind, empowering thing to do.
I love that. Thank you so much. I think we've covered a lot of ground, so I think we're going to sign off for now. We'll talk to everybody next time. You've been listening to the Parenting Horizons podcast. If you would like to reach Elizabeth Cohen, you can go to www.centerforcbtinnyc.com.
And if you'd like to reach Julie Ross, please go to www.parentinghorizons.com.